Okay, today we're going to be talking about two things actually. We're going to be talking about anemia, and then we're also going to be talking about lab interpretation. And this is Dr. Parve. So make sure that you do the readings that are listed on your topical outline and in the overview before listening to this lecture. It'll help you to understand the lecture a little bit better. These are things that we'll discuss in the lecture. I recommend having your Fishbach and Dunning lab book open or at least next to you when we're talking so you can pause the lecture and look up some things. If you don't have this book, I highly recommend it. I still use it to this day in practice. It's a wonderful book. So we will discuss how to diagnose and treat different anemias. We will not go over though like thalassemias and sideroblastic anemias, some of those more specialized anemias, but we will go over iron deficiency anemia, anemia of chronic disease, B12 or folate deficiencies. So anemia is defined as a decrease in the oxygen carrying capabilities of the blood, which is why sometimes people that are anemic are short of breath. Also, iron deficiency anemia is the most common anemia in the world. And many times patients don't have any symptoms that they're anemic until their hemoglobin gets below 10. So I'm going to show you how to find out they're anemic before their hemoglobin drops below 10 and before they have symptoms. Okay, so we're going to talk a lot about the red blood cells. So the red blood cells are formed in the bone marrow, and when they're mature, they're released into circulation. And what happens is in order to increase the production of red blood cells, it happens when you have a decrease in oxygen. So patients that are hypoxic, that would make them also increase the production of their red blood cells. So the survival of a red blood cell is approximately 120 days. And if you remember your diabetic lectures, you remember that we check hemoglobin A1C about every 3 months on a diabetic patient. And that's because the glucose binds to the RBC. And so every 3 months when they die, the glucose goes with them, so that we know that we can kind of read the glucose a little bit better every 3 months. The RBCs are cleared by the spleen. And we'll talk a little bit about reticulocytes. Those are the new RBCs that are in circulation. And if your body doesn't produce any new RBCs, your hemoglobin will drop about 1 gram a week. So when evaluating the hemogram, your normal hemoglobin hematocrit ratio should be 1 to 3. And I do know that in the past this has been a question on the exam, or at least on the quiz. So hemoglobin is a complex protein, and oxygen binds to the iron in heme, which is why we're going to talk a lot about iron deficiency anemia as well. If there's a problem with any part of the molecule, it sometimes is not functional. So for visual learners, I have some pictures. You can also go on YouTube and type in anemia or hemoglobin, and there's some really cool videos that you can watch if you're having troubles understanding exactly, or if you are a visual learner and you really want to see a little more action than just a lecture, PowerPoint lecture. Okay, so first we're going to talk about the size. So the MCV tells us the size of the red blood cell. So the normal size, as you can see here on the screen, is 80 to 96. And if they're too small, which is microcytic, then they're going to be less than 80. If they're really big, the MCV is going to be greater than 96. And this may not seem like it means much to you right now, but as we get going on the lecture, you'll understand a little bit more. And my hope is that now when you go into clinicals, when you see a CBC, just because the hemoglobin and hematocrit are not low, you're going to be like, they're fine. I want you to look at the whole CBC from now on and see what you can pick up, okay? And the MCV allows you to classify the type of anemias to further determine the etiology. So if they're microcytic, they could have certain types of anemias, but usually normocytic we actually see with people with chronic disease because like their body kind of normalizes the red blood cells even though they have anemia of chronic disease. If they're macrocytic or really large, we tend to see that more in alcoholism, COPD, and certain malignancies. So this is morphology of the red blood cells, and you won't see all of this on a CBC, but you'll see some of it on a diff and some of it also on a smear. But I think it's a really nice chart. I'm going to try and see if I can get IT to, when they make up my PowerPoint slides, if they make them all one page, because I've got a lot of really nice charts that you can take with you to clinic. Okay, so let's start with microcytosis. So maybe we were just talking about the size of the cells. So if you look here, on the left-hand side, those are the normal ones. On the right-hand side, those are the smaller ones. And you can see the microcytic ones. So if you're looking under a microscope, you could definitely see the difference. The ones on the right also look like they're a little hypochromic, and we'll talk about that a little bit later. So I'm a visual person, so I thought that might help you look at that. And we see that in iron deficient anemia, as well as some thalassemias. So some of the causes of microcytic anemia are inadequate intake or uptake of iron, which we see sometimes in developing countries, or we see in people with poor diets. Also anemia of chronic disease. Sometimes these are the early signs that they have a chronic disease, is the microcytic anemia, and then sometimes it normalizes into normocytic. We'll see it in the thalassemias and the sideroblastic anemias, which those two we're not going to be talking about today. So the content of the hemoglobin, as you can see, they have, if you go down a little bit further, they have colors. So the hemoglobin is the source of the cell's color. So if they're normochromic, then they're the normal color. If they're hypochromic, then they're pale. And you saw that on the last slide that I showed you was a couple slides ago, where the little lighter colored ones, those would be the hypochromic ones. Oh, there you go. I got another slide. Sorry. Maybe that'll help you too. So you can see they kind of seem to be really pale in the center as opposed to the normochromic on the right. So now we're going to now we're going to talk about the RDWs. And so the RBC size, normally all the RBCs are about the same size. You have some immature ones that are new ones that are a little bit smaller, but usually they're all about the same size. So they give you like, if you want to know what the normals are, less than 15% of them should not be equal. So if you have 15% of them that are not all the same size, that's normal. If you have more than 15%, that's considered abnormal, whether they're smaller or bigger. And this is one of the earliest laboratory indicators of anemia, as opposed to the hemoglobin and hematocrit. How many of you have seen a reticulocyte? I can't even talk today. I don't know why I'm lecturing. Reticulocyte count. You see that a lot in sickle cell patients. You'll see these done, but you can definitely do them in people that are do not have sickle cell. So the body's normal response to anemia is to attempt to correct it by increasing the number of new cells, which are called reticulocytes. So that is the normal response. The reticulocytes develop and mature in the bone marrow, and they circulate about 1 day before they become mature. So we were just talking about when you look at a CBC and the different sizes of them, that's when you might be seeing different sizes. Normally about 1% of RBCs are reticulocytes. I don't know if you guys find this interesting, but I've read a lot of CBCs when I was in practice, and when I started doing this lecture, I'm like, I really should have been looking a little bit closer. So I'm hoping that you guys are, when you get into practice and even in your clinical rotations, that you're going to start looking at a CBC a little bit closer. I think a lot of people order CBCs, and I don't always know if they know what they're looking for. So this is a slide I got online. I think it's really nice, especially the first couple lines of it, where we talk about, so the MCV, so the microcytic, we're going to see that in iron deficiency anemia or in chronic infections. The normocytic we're going to see in chronic disease like we talked about before, our early iron deficient anemia. And then the macrocytic we might see in megaloblastic anemias or liver disease or alcoholism. The other ones are more specialty things. So the good news is if you get a CBC and you're finding some of the stuff and you're not sure what to do, you can go and look in your lab book, and your lab book really will tell you some interesting things. So if you look on page, I'm going to grab my lab book, it's right next to me. So if you look on page 88, it talks about red blood cell count, and it tells you things like, so what if it's elevated? What if something's low? What if the hematocrit's elevated? What if it's low? What about the hemoglobin? It tells you some of the clinical indications. So if you go on page 93, it talks about hemoglobin. And it says decreased hemoglobin levels are found in anemias. So they recommend like you look for iron deficiency, pernicious anemias, liver disease, hypothyroidism, hemorrhaging, chronic or acute, a hemolytic anemia caused by a transfusion of incompatible blood or reactions to chemicals or drugs, reactions to infectious agents, reaction to physical agents such as severe burns or even artificial heart valves. And then you might also see the various systemic diseases such as Hodgkin's disease, leukemias, lymphomas, lupus, carcinomas, and etc. So that's why I think your book is really nice, because you're going to be talking to the patient, getting their history, getting their physical, finding out what they're coming in for. You're going to be asking them questions. And then sometimes when you ask them the questions, get the history, do the physical, and then you get your lab work back, you're able to kind of figure out more what they have. You don't want to do just one or the other. You definitely want to do both of them together. Okay, so let's talk about iron deficiency anemia, which you're going to see probably a lot of. So the etiology is usually chronic bleeding, so menorrhagia, which means heavy menstrual bleeding, a peptic ulcer that might be bleeding, stomach cancer, ulcerative colitis, intestinal cancer, hemorrhoids. It's got to be pretty bad hemorrhoids in order to become anemic. Or decreased iron intake. A lot of people do not get a lot of iron in their diets nowadays, or they might not be getting enough if they're pregnant, lactating, or young teenagers. So when we're done with the lecture, you can definitely go to this website and pull this up. It's a really nice document. I have it printed up next to me. It just tells you a lot about the CBC. It says the blood test results, CBC explained, and this is the chart that you're going to pull up, and it tells you the substance. So on the left-hand side, I'll tell you about the white blood cell count. What does it mean when it's low? What does it mean when it's high? And what are the references? So it's a really nice chart to take with you, I think, to your clinical rotations and to keep even after you're done with school. Okay, so symptoms of anemia. So lots of times people with anemia, now remember, they don't always get symptoms until their hemoglobin's less than 10. I mean, I've seen patients come in with hemoglobins of 6, and they don't always have these symptoms. They just might be fatigued, and I'm always very surprised when I get their CBC back. So some of the symptoms are tachycardia. Sometimes they might actually have rales or right upper quadrant pain. They have something called a hemic murmur. If you're not sure what that sounds like, you can probably go to YouTube and find a video that'll play a hemic murmur for you, or you can ask your preceptors, or distended neck vein. And then neuro-wise, they'll get paresthesia. They'll get this something called stocking glove neuropathy, which we'll talk about in a few minutes. They'll have difficulty with balance, confusion, in extreme cases of vitamin B12 deficiency or folate deficiency anemia. And these are just some of the other symptoms. Sometimes they'll get the swollen tongue. Now we're going to kind of break down which anemias give you which of these symptoms in a few minutes. Those are a lot of symptoms just for anemia. If you look, a lot of these symptoms could be for something else too. So a physical symptom that you might notice is their conjunctival sac is very pale. And if you notice, at least when I'm in practice, and if somebody says they're fatigued, that's one of the first things that I look at to see how pale it is. What I recommend is that you look at your own in the mirror. Unless you're anemic, then it's not going to look right. But if you're not anemic, look at yours and then start comparing it to other people. And then also look at the palms on the bottom, how pink the one is on the right, and then the one that's so much paler on the left. These are just some physical signs you might see. There's also in their fingernails, look at these little like divots in them, and that's a sign of iron deficiency anemia. Personally, I've never seen this in practice, but you know how we have you in your physical exam look at their hands and their fingers? This is something you also want to look for. Just remember, iron deficiency anemia is a manifestation of an underlying process. So you need to find out what's causing the deficiency or the anemia. So let's talk about iron deficiency anemia, how we can treat that. So first of all, it can be pretty simple. You can just give them a prescription for ferrous sulfate, usually 300 to 325 milligrams 3 times a day. And food decreases absorption, so you need to take it 1 hour before meals, and preferably with something with vitamin C in it. And usually orange juice is the drink of choice. And then you're going to have the patient follow up in 3 to 4 weeks. And if the hemoglobin level is increased by 1 in 3 to 4 weeks, then you're going to continue the treatment for 3 to 6 months. And then the hematocrit should return to normal after about 2 months. Then you're going to continue therapy for another 6 to 12 months to replace the body's iron stores in the bone marrow. So you don't want to just get them to normal. You want to make sure that they have some iron stores in case they need it for later. There's also an iron shot that you can give called NFED, and there's also IV iron for severe cases. So the question a lot of students have is, so when do we refer them to somebody else? Okay. You can refer them when the hemoglobin is not increasing after 1 month of therapy. And I usually recommend that you refer them first to a physician, and they can do any other workups that they think they need to do. If you notice that there's a steady downward trend of the hematocrit despite the treatments that you're giving them, and then the lab finding shows that the hemoglobin is less than 9.0 or the hematocrit is less than 27, then you're going to start suspecting underlying inflammatory, infectious, or malignant diseases. So now let's talk about folic acid deficiency. And I've never had a patient who came back with a low folic acid in primary care. But folic acid is a water-soluble B-complex vitamin, and it's found in abundance in peanuts, fruits, and vegetables. And it's excreted in the urine. So if you have a deficiency of folic acid, you're going to see a macrocytic normochromic anemia. It's seen most commonly in the elderly or the alcoholic. Remember, macrocytic we see in alcoholism. And impoverished persons and the malabsorption syndromes, which include sprue and celiac disease. You also can see malabsorption syndrome in people that have had bariatric surgery. And of course, a poor diet. And then there are some medicines also that can cause a decrease in folic acid absorption. One thing I found interesting was gray hair. And this doesn't mean that everybody that gets premature gray hair has a folic acid deficiency, but if somebody's like, you know what, I noticed my hair is turning gray and they're young and it doesn't seem to run in the family, you definitely want to check their folic acid. So it's an essential nutrient for maintaining healthy levels in your body, which are needed for healthy hair. So gray hair can be a sign of folic acid deficiency. Obviously, if you're older, it's not a sign. And once you restore their folic acid levels to normal, their hair actually will go back to the normal color. At least the new hair that's coming in will go back to the normal color. So I think that's really interesting. Who would have thought, huh? So some of the signs and symptoms of folic acid deficiency are similar to the first couple slides I showed you about anemia symptoms. So fatigue, poor appetite, headache, pale skin, gray hair like we just talked about. Sometimes they'll have a red, irritated, and swollen tongue. I did have a patient with that one time who kept saying their tongue was swollen. I thought maybe they were having an allergic reaction to something, but it actually ended up being a B12 deficiency. Mouth ulcers, shortness of breath and lightheadedness, and then a change in bowel patterns, usually diarrhea. So before you diagnose them with like Crohn's or irritable bowel syndrome, check their folic acid. These are the levels that you'll most likely see in a patient with folic acid deficiency. And the treatment is usually treated with 1,000 micrograms of folic acid. You give it once a day. Usually it corrects the anemia in 2 months. And to get enough folic acid, you should have the patient eat fortified grains, cereals, and bread products, dried beans and legumes, poultry, pork, liver, and shellfish, which is a problem if they're either a vegan or vegetarian, and a variety of fresh fruits, especially dark leafy green vegetables. And vitamin B12 and folic acid depend on normally functioning intestinal mucosa for their absorption and are important for the production of red blood cells. So let's talk about vitamin B12 deficiencies. So vitamin B12 is found in abundance in foods of animal origin. So if you're a vegan or a vegetarian, if you have a patient that comes in with some of these symptoms, and by the history you're asking them about their food intake, you find out they're vegetarian or vegan, you definitely might want to check a B12. And then there's 2 types of B12 deficiencies. There's like a dietary B12 deficiency, and then there's something called pernicious anemia. And people with pernicious anemia, they can't absorb enough of the vitamin B12 from their food. And there's other factors that can also cause a vitamin B12 deficiency: surgery, medicines, diets. And severe or long-lasting pernicious anemia can damage the heart, brain, and other organs in the body. And there's something called stocking glove neuropathy, which is on the next slide. And the oral form is absorbed in the distal portion of the small intestines, and it's not absorbed very well there, which is why the injectable B12 seems to work a lot better. In the lab, you're going to see microcytosis on your RBCs or in your CBC. And during treatment, you want to make sure that you monitor their potassium. So here's some signs, physical signs of pernicious anemia. So you can see on the right the stocking glove neuropathy, and then the swollen tongue I was talking about. So I'll tell you a quick patient story. I had a patient that came in to me to see me. I was working at a rural clinic, and she had already seen the neurologist several times and had a bunch of tests done, and she was still dropping things. She said like her hands would go numb when she dropped things. And I tested her. I did a Phelan's test and a Tinel's, which you learned in health assessment, to check for carpal tunnel, and those were both negative. So I said, And she's like, she'll even be holding like a cup of water and it'll drop. It's just very bizarre. And so I checked a B12. Lo and behold, she was very low in B12. And after several months of getting B12 injections, she no longer had that problem. So even if a patient tells you they've had a workup, or they've been to a neurologist, or they've been to see multiple doctors, make sure you review the chart. And if they have these symptoms, make sure that somebody hopefully did a B12. Okay, so this is a little chart that I made up by doing the research for this lecture. Also in your Fishbach book on page 119, I have my book right here, so I'm going to open up to page 119. They have a very nice chart that I think is as good or better than my chart that you might like. And so that's table 2.6 on page 119 of Fishbach and Dunning. And it just has kind of the same thing. It talks about the ferritin, the iron, and the iron saturation, and whether it's decreased or increased or normal, and all these different types of anemias or diseases. So that's why this book is also very, very nice. Okay, additional testing. Always, if somebody comes back with anemia, always make sure to check a urine and a stool, because maybe they have hematuria that's microscopic, and maybe they do have some occult blood that they haven't been able to see yet in their stools. So you always want to make sure they're not bleeding from someplace else, especially menopausal women who you know aren't having periods, so they shouldn't be anemic, and men as well. So these are some other labs that we usually recommend if you're suspecting by their CBC that they have one of these diseases. These are the additional lab testing that you're going to be doing. I don't know if any of you have ever seen any of these ordered or done in clinic, but you can also suggest them as a student if you bring this chart along with you. So let's talk about the treatments. So for pernicious anemia, they're going to need a vitamin B12 injection once a week daily for 1 week, and then weekly for 1 month, and then once a month. Okay, they should follow up in 2 weeks, and you're going to check the hematocrit every 6 months. And then they usually recommend endoscopy every 5 years just to make sure they don't have some type of problem with their stomach that's causing this pernicious anemia. For B12 deficiency, depending on what their deficiency is, if it's really low, then you're also going to do B12 injections. But if it's just kind of on the borderline and they're not having a lot of symptoms, you could try and work with a nutritionist and get them to eat more foods that have B12 in them. So now I'm going to go over a couple case studies because you know that there's going to be case studies on your quizzes and exams. So these are the normal values that we're going to use just for these case studies, and we're going to use them for men and women. Even though we know that that's not true in real life, they both have different values. We're going to, for the sake of the case studies, we're going to use the same values for men or women. Okay, so first you're going to examine a 65-year-old woman. She has rheumatoid arthritis, and you find the following results in the hemogram. So you're going to start from the top and go down. So the hemoglobin is decreased, her hematocrit is decreased, her MCV is normal, as are her RDWs. Her serum iron is decreased, her TIBC is decreased, and her transferrin saturation is normal, as well as her serum ferritin. So if you look at the chart on the right, I put in the normal values so you can kind of look over there. However, you don't have the normal values of the iron ones. So the iron panel, so you might want to grab your Fishbach book and look at that, or the chart that I did a couple of slides back. So what do you think her diagnosis is after just reviewing her labs? Now we're not doing a physical exam. We just know about this woman, and we're looking at her CBC because our partner's on vacation. So what do you think your diagnosis would be? I'm going to give you a second to answer it in your head or out loud. So this woman has anemia of chronic disease. Hopefully that's what you guessed. Okay, next case study. So your partner again is on vacation. They take a lot of vacation. I review the following labs, and this is a 47-year-old woman, and you really don't know a whole lot about her, except that these are her labs, and she saw your partner a week ago. So if you look at her labs, her hemoglobin and her hematocrit are both lower. Her MCV is lower, but her RDWs are higher, which means what? Which means that there's a lot of different red blood cells that are different sizes, which means that there's a lot of either most likely new ones. And so when you get a lot of new ones, remember they're a little bit smaller. So why? You have to think, so why is she producing so many new ones? So you see this, and so you say, well, I'm going to order some iron studies. And when you get your iron studies, you can see this is what they are. And what is your suggested diagnosis? Let you think for a second. If you need to put it on pause, which is what I would recommend, get your book out, take some time, look at the charts. I would suggest that you try and figure this out before you hear me give you the answer. That's the way I learn anyway. Okay, and the answer is she has iron deficiency anemia. So most likely, she's 47, she's still menstruating. Maybe it could be from that. Maybe she has heavy periods. We'd have to find out a little bit more about her. Okay, the last case study. So we see a 47-year-old man, and he has the following results on the hemogram. And again, your partner is out of town for the day. So you're just getting these across your desk. This happens frequently. Sometimes they haven't even done their note because they went out of town. So you might not know anything about this patient except this. So you can see that his hemoglobin and hematocrit are a little bit elevated, but nothing to be too worried about. It's not like he has hemochromatosis, so you shouldn't worry about that. His MCV are large inside, which means what? He's macrocytic. So you decide that you're going to order a folate and a B12, and lo and behold, they're decreased. So what do you think could be causing these lab values? Obviously, it's going to be a little bit of a guess because you didn't actually see the patient. But again, get out your charts, put me on pause, and think this one through. Okay, well, hopefully you got alcoholism because that's what we're seeing with this patient. And this is a resource where I got the next chart, which I kind of like too. Everybody has their own way of learning, so you need to find a chart that's going to help you the most. I think this is a really nice chart because it also has a blood smear that has some interesting things on there on the lower left. Okay, so if you need to take a little bit of a break, it's up to you, but we're going to start talking about liver function tests. And liver function tests are the markers of liver injury. And of course, you already had patho and anatomy and physiology, so you should know the function of the liver. The function of the liver is to the production of plasma proteins, glucose homeostasis, and production occurs significantly at night, which you might have learned in your diabetic lecture. Also lipoprotein synthesis, production of clotting factor, detoxification, bile acid production, LDL production. If you remember, LDL is the bad cholesterol. And the storage of vitamin B12, and then your fat-soluble vitamins, which are A, D, E, and K. So we're not going to really spend a lot of time at all talking about the liver. You're going to be discussing that in APN2 when you get a lecture in there. Also, you can review your labs in your lab book, Fischbach and Dunning, on pages 401 to 411. So how reliable is the LFT? Some people order them a lot, and I think they don't always know how to read them. So LFTs, liver function tests, are not really a good indicator of the function of the liver. Really what's going to tell you is if there's any injury to the liver. So it's more that's what you should use it for. So if they're on a statin, the LFT is going to tell you if there's some injury to the liver because of the statins. And for example, 33% of patients with chronic hepatitis C have a normal LFT. Interesting. So I found this chart online and I thought it was really interesting. I'm just going to go through it quickly. You can look at it closer a little bit later. And at the very end, I believe I have the resource where I got it from. So if you need to look it up, you can. So sometimes you get an LFT across your desk and either your partner's on vacation or you're not sure what you're supposed to do. So a patient comes in, you draw these LFTs because somebody told you you're supposed to draw them every 6 months after somebody's on a statin. Or they're a new patient and you have to draw them and you see some of these abnormalities and you start to panic. So a mildly elevated ALT could be normal depending on the person's gender or other things. But you should still consider muscle injury or myopathy, which is what? Myopathy is something we might see in people having reaction to statins. Okay, and then alcoholic hepatitis. You might just see a minimal elevation of the AST and the ALT. And I tell you how I remember ALT and AST. I don't know if it's going to work for you, but it works for me. The AST is a short-term damage, and the ALT is a long-term. That's how I remember the S and the L. So the AST, if the level is greater than 500, it's unlikely to be just from alcoholism. So remember the 47-year-old that we were looking at in the case study? We'll say you get an AST back and it's greater than 500. You don't want to assume it's from alcoholism. You want to check and make sure he's not taking too much acetaminophen or Tylenol. Because lots of times people have, aches and pains and they forget that there's Tylenol or acetaminophen in a lot of other products. And they could actually be toxic. And that's why their AST is elevated. You also can see that elevated in fatty liver. And you can check if somebody has a fatty liver with an ultrasound. Okay. So sometimes people with a common bile duct stone, it seems like they're having acute hepatitis. If you see an isolated elevation of GGT level, it could be because of alcohol aromatic medications, but usually there's no really actual liver disease. And if you see an isolated elevation of the AP level, you should consider bone growth or injury. And the AP here is really the alkaline phosphatase, or sometimes we see that in bone cancer, which is unfortunate. or it can also be elevated sometimes late in pregnancy. You might also order Billy levels even in adults. And there's something called Gilbert syndrome, which looks like Gilbert, but it's called Gilbert syndrome. And I learned about Gilbert when my oldest son, wasn't feeling well and his eyes turned yellow, which is not good. And he was probably about 14 or 15 years old. And I took him to the doctor, and we had lived in Africa for a while, so they thought maybe he had picked up something there. They weren't sure, but they run a bunch of tests, and really his conjugated Billy was elevated. So then we found out he had Gilbert's syndrome. Usually doesn't cause any problems, except that sometimes you turn a little bit yellow. And it seems to be worse when somebody's sick. So you want to make sure if you get somebody with an elevated unconjugated Billy level, that you don't freak out and think they have liver cancer, that you also think that there could be some other things that they could have that's going on. And then it just goes on to talk about low albumin and blood and ammonia levels. Oops, sorry, back. So I thought this was a really interesting chart. I had never seen it before. I wish I had it when I was practicing full-time in primary care. But these are some of the causes of elevated ALTs or ASTs in asymptomatic patients. So you can see it's got the ABCs, and then it skips a couple, and it's got M. But this is a really nice chart to have with you, so that if you see somebody with any of these things, you can kind of figure out, first of all, could it be one of the things on the right-hand side. Some symptoms of liver disorders include weakness, fatigue. Sounds like people with anemia, doesn't it? Which is why primary care is complicated. You actually end up being like a detective when you work in primary care. So weakness, fatigue, weight loss, jaundice, yellow skin and eyes. And remember, you might also see that in Gilbert syndrome. Symptoms of nephritic syndrome, which is swelling around the eyes, the belly, and the legs. Dark urine or light stools. Nausea, vomiting, diarrhea, and abdominal pain. I did have a patient come see me once at the free clinic, and he was freaking out because he was a drinker, and his urine was brown. And he brought it in, and he was seriously, visibly shaken up. Well, I found out he was on Flagyl, so it was actually a really easy diagnosis. Okay, so hopefully this kind of helps you look at labs a little bit closer. If you have any questions, you can put them on the question forum in Angel, or you can email me. And also for the question forum, if you have any tips or anything that you've seen in practice that you think are fun, please, you can always post those on the question forum too. Because I see that you guys are really good about talking back and forth with each other, which I think is great.